Hello, everyone, and welcome to the Patient Health Alliance NMOSD Master Class. We welcome everyone in attendance and remind attendees that the Patient Health Alliance is a source of information and education for NMOSD and related conditions. The content of the following presentation is based entirely on published data or expert opinion. PHA is not a clinical provider and does not offer diagnostic, therapeutic, or clinical care recommendations or advice on personal health. All patients and caregivers are advised to consult with their healthcare team for specific information. There are overarching goals to the NMOSD Master Class. These include a practical update of latest information on a specific topic. The session is intended to illustrate key themes and/or clinical pearls related to that topic. It's formatted to be inclusive of all audiences, including non-specialists, neurologists, as well as patients and caregivers. There will be time for an active question and answer discussion period to emphasize key points. My name is Michael Yeaman, and I hope everyone is doing well today. We are delighted to invite Dr. Eoin Flanagan here with us today. Dr. Flanagan is professor of neurology and chair of the Division of Multiple Sclerosis and Autoimmune Neurology at the Mayo Clinic in Rochester, Minnesota. And Dr. Flanagan is also the Marilyn A. Park and Moon S. Park chair for the Center for Multiple Sclerosis and Autoimmune Neurology. Dr. Flanagan, we're greatly appreciative of your time today, and we look forward to your discussion on the topic of emerging therapies for MOGAD.
I'm delighted to be here, and I'm really excited to highlight this interesting topic that's rapidly evolving. So my title of my talk will be on emerging therapies for myelin oligodendrocyte glycoprotein antibody-associated disease. We sometimes call MOG antibody-associated disease, or MOGAD for short. These are my disclosures here. Some of the treatments I'll mention, I'm involved in some of the clinical trials for those, and some of the disclosures are relevant to those here. And everything that we talk about today is off-label because we don't have any FDA-approved medications for MOGAD yet, but we're hopeful into the future that we will get some FDA-approved medications. The learning objectives today are really to talk a little bit about the acute management of MOGAD attacks, to highlight the optimal attack prevention treatments, and to highlight some of the clinical trials and emerging treatments in MOG antibody-associated disease. So when we think about central nervous system demyelinating disease, we can think about three major diseases. The first has been around for centuries even, multiple sclerosis, and ranges anywhere from asymptomatic multiple sclerosis, something we call radiologically isolated syndrome, all the way to secondary progressive MS. And we've really done quite well in the field of MS, particularly in the last 20 years, and we now have over 20 approved medications that can really target the disease very well. The second recognized disease was aquaporin 4 antibody positive neuromyelitis optica spectrum disorder, termed NMOSD for short. And that is a little bit different in that that had an antibody blood test that you could make the diagnosis with to a water channel in the brain. And also, as I'll show on the next slide, we've made very good accelerations in treatment in that disease, and we now have many different approved treatments for that condition. The last disease I'll mention, and which will be the focus of today's talk, is myelin oligodendrocyte glycoprotein antibody-associated disease. And the difference between these two diseases is the aquaporin 4 is located on the astrocyte, which is one of the cells within the brain that has connections between different cells, and it's to a water channel on those astrocytes. The MOG is a protein on the surface of what we call the oligodendrocyte, and the oligodendrocyte is involved in putting the insulation on the nerves. So it insulates all your nerves. And when you have the MOG antibody, that will attack that oligodendrocyte and remove that insulation from those nerves, and in that way cause problems with the signal and difficulties, for example, in vision, or difficulties with movement, or cause confusion. So just like if you had a mouse eating at your cable to your television, and if it ate away all the insulation, the signal to your TV would be bad. Similarly, in MOG antibody disease, there's an attack on that insulation around the nerve within the central nervous system, the brain, the spinal cord, and the optic nerve. And this is just to highlight a little timeline of neuromyelitis optica spectrum disorder, because MOG antibody-associated disease is kind of following a similar timeline. And back in 1999, Dr. Brian Weinschenker and Dr. Dean Wingerchuk at the Mayo Clinic had reported that this neuromyelitis optica spectrum disorder seemed to be different to MS. At that time, it was just thought to be a severe form of MS, but the MS treatments didn't seem to work very well, and it seemed a little bit different. And at the time, Dr. Lucanetti looked under the microscope and she found there was a lot of antibodies deposited and also part of the immune system called complement. And then in 2004 and 5, there was a breakthrough, and Dr. Van der Lennen at the Mayo Clinic discovered the aquaporin 4 antibody. And then what happened was many researchers went to the lab and they tried to discover what are the mechanisms that are happening that are causing this disease to cause its symptoms. And that included B cells, complement, interleukin 6, CD20, CD19, B cells, so a variety of parts of the immune system. And that eventually led to treatments that were going to target those areas in the immune system. And now all of these treatments have been shown to be very effective. So it was really a nice showing of how you learn about the disease and how it's working. And then you target those areas that are a problem in the immune system, and you can get many different approved medications, which are highly, highly effective. So now we have many different approved medications for neuromyelitis optica spectrum disorder. But with MOG antibody-associated disease, we are just starting out with these clinical trials, and some of those are starting to complete, as we'll talk about over the next many slides. So we've been very successful in MS, and we've been very successful in NMOSD. We need to replicate that success in MOGAD. So what are the attack types of MOGAD? Well, MOGAD can cause, the most common presentation is actually optic neuritis or optic nerve inflammation, but also in children. Children can tend to get this, what's called ADEM, acute disseminated encephalomyelitis, which means inflammation within the brain and the spinal cord. So sometimes children will become confused or develop weakness in their arms and legs, and that can be quite common in children. And then when you go into adulthood, the optic neuritis or optic nerve inflammation really takes hold as the dominant manifestation. And patients who present with that, they often have pain with eye movements and develop then vision loss that comes on over the course of a few days to weeks. It usually plateaus. And then with treatment, it will usually improve over time. And with treatment, we hope to accelerate the recovery and get people back to normal after they have these episodes. The MOGAD can also involve the spinal cord. So you can get numbness and weakness in the extremities. You can get blockage of the bladder, requiring a urinary catheter. You can get blockage of the bowels. So these are the main areas it affects: the brain, the spinal cord, and the optic nerve, with the optic nerve being really the most common, and it probably accounts for 70% of all the attacks, I would say, in MOGAD. So really very optic nerve central disease. But today our focus is not so much on the diagnosis of this condition, which can be diagnosed with this MOG antibody, as we mentioned, but we're going to focus in really on the types of treatments that we can use in this condition. So if we start off with acute attack treatment, so the MOG antibody-associated disease presents in the form of attacks. So people get these episodes that come on over days to weeks, they plateau, and then they get better. And when they have these episodes, it can be pretty debilitating. Patients can be blind in one or both eyes. They may be confused. They may, they can even be so severe that they're having seizures or be in a coma. They can have difficulty with walking from paralysis, from spinal cord involvement. So many times patients will end up in the hospital. And we try and treat these acute attacks with immunotherapy. And we know that our favorite immunotherapy in the field of neuroimmunology is corticosteroids, because they work really well at resolving that kind of active inflammation. And this was a study from the French group just highlighting that the earlier you can get in with your steroids, the better the outcome. So people's vision will be improved if you get in within the first 10 days. And there'll be less damage and more preserved thickness of your optic nerve if you can get in early with treatment. So one message to people out there, if you have MOGAD, is when you have a relapse, it's really important that you get in quickly and get it treated quickly, because the earlier you treat it, the better the outcomes. What we use is a medication, most commonly is a medication called intravenous methylprednisolone, also known as Solumedrol. And that's given 1,000 milligrams or a gram a day for 5 days. And many patients will get this while they're in the hospital. But you can actually give this orally with prednisone. And unfortunately, prednisone doesn't come in a very large size. So we have to give 25, 50 milligram tablets to patients to take that. But the benefit of that is that you don't need to go to an infusion center. You don't need to go to a hospital. So if somebody's in a rural region, it's hard to get to a local facility. They can get started on the treatment pretty quickly. And this led to the concept John Chen at the Mayo Clinic has put forward, which is the steroid in the pocket. So if you're a patient with MOGAD and you're worried about getting one of these optic nerve attacks where you're going to lose vision, then you can have this steroid in the pocket. And if it's a Friday night, you can't get through to your doctor, you could potentially take it. And then, you would try and get seen as soon as possible after that, but not delay the treatment too much. And he's looking at this currently in the form of a clinical trial. So early steroids seem to be beneficial. And there's even some studies that suggest that if you get in with early steroids, then that may reduce your risk of having a future relapse. So a second treatment that we have for MOGAD is something called plasma exchange. And this is a dialysis-like treatment that clears out your antibodies. So we know that the MOG antibody-associated disease, the MOG antibody, is the big culprit and causing a problem. So one way of getting rid of that is you put a central line often in the neck, and then you can clear out all those antibodies. And that seems to also be a very useful strategy. It's not needed in everybody, but in people with very severe attacks, we usually will start that early on to try and get the recovery going. And again, like steroids, the earlier, the better for the plasma exchange. But some patients will just require the steroids, and that will be sufficient. But a couple of studies, one across Europe, showed the benefit of potentially of plasma exchange. These were observational studies, so not a full clinical trial, but really suggesting that plasma exchange can have a role in accelerating the recovery, particularly in those people who don't improve after those first 5 days of steroids. You have your optic nerve inflammation, your vision is still gone. You should consider whether you would ask about this plasma exchange. And we think that earlier is better. And Dr. John Chen and Elias Terturchas from Johns Hopkins are now running a study looking at a comparison of early plasma exchange versus kind of the typical delayed plasma exchange to see if you get in early and hit hard early, will that be better? So that trial will help guide our treatment into the future. Now, we just talked about removing all your antibodies. Another way you could target the antibody is by adding antibodies to the mix. And that's something we call intravenous immunoglobulin, or IVIG. And that's where you give people antibodies, pooled antibodies in the general population. And the idea is you kind of neutralize the bad MOG antibodies. It works in other ways in helping saturate some of the receptors, but it has lots of different mechanisms. But a good way to think about it is it neutralizes. And sometimes this is also used as an acute attack, but as I'll talk about later, may not be quite as effective as the plasma exchange in our experience. And we also use this treatment as an attack prevention treatment where we can give it on a regular basis because it doesn't need a central line. It's not as complicated as the plasma exchange. So we can sometimes give that as a maintenance treatment, and that's a commonly used treatment to prevent attacks in MOG antibody disease. Now, just to highlight something here, some patients, very rarely, I would say 2%, 3% of patients, particularly in children, can have very severe attacks of MOGAD. So that means they go to the hospital, they can become comatose, they can even be in the neuro ICU and have a very severe attack. This is usually with the first episode. And a lot of times when we do our scans, we'll see lots of swelling and lots of pressure within the brain, higher pressure within the brain. And sometimes that pressure can start to compress on items. Like here, you'll see the brainstem getting compressed by this pressure pushing down on the brain here. So all of this severe swelling in the brain can really be a problem. So for these patients, we really want to treat them aggressively. And there's been some studies suggesting that you can use a medication called tocilizumab or an interleukin-6 receptor blocker. We'll talk a lot about interleukin-6 receptor blockers over the next many slides, but the way I think about it, it's like the fuel for your immune system. So it's the fuel that helps your immune system make all those antibodies. So if you can block that fuel from getting into the vehicle or getting into the immune system, then that's a way you can prevent that. And it works very quickly. So sometimes it's been used in some of these very severe cases. But even in some of these cases, we've had to call in our neurosurgeons and we've had to remove the skull from the head to kind of prevent that compression of swelling and allow the brain swell out a little bit. And then the skull gets put back on many weeks later. So sometimes we need these life-saving, heroic neurosurgical interventions for these very severe attacks. Very rare, but if it does happen, it's important that it's treated aggressively because these can be life-threatening. Another thing, just to mention, sometimes even in the regular acute attacks, we can use some of these treatments like the IL-6 receptor blockers, even with optic neuritis or with spinal cord inflammation. Even if it's not a life-threatening attack, we can try and use them at this early on after the initial treatment with steroids or plasma exchange. We can use it early on, and it can maybe help accelerate the recovery. So we're trying to look into see if these treatments might be useful. Now, this is all observational data in a small number of patients, but suggests that there might be some utility in accelerating recovery. So the second step, after we treat the acute attack and we try and get as much recovery as we can, then we want to decide, do we need to try and prevent future attacks, and what is the risk of future attacks? And the interesting thing about MOGAD is that it kind of splits in two. About half of patients will never have another attack. So that group is what we call monophasic, or they just have a single attack. So we don't want to put all of these patients on long-term immunosuppression and increase the risk of infection and complications, and it's very costly if they're destined never to have another attack. On the other hand, about half of patients will go on to have relapsing disease, which means they have 2 or more episodes. And at this stage, once you have 2 episodes, we tend to come in with the long-term treatment to try and prevent future relapses, because with each attack, we can see disability, we show here, and with each attack, you can get some additional disability. So you lose some ground each time you have an attack. So we don't like those attacks to happen. And when people do have attacks, if they're blind in one or both eyes, they can't work, it's very disabling for them. So at this stage, we try to get in with treatment. So usually after one attack, a lot of times we don't treat them and we observe, but after 2 or more attacks, we will often treat. But there are rare exceptions that we'll talk about over the next many slides. So many people ask us, what is the risk? So here was a study from the Oxford group showing that about just over 1/3 of patients relapse at 8 years in this cohort. So overall, in the long term, we think the risk is about 50-50. And this was another study from a French group showing about a 50-50% risk of relapse in the long term. And what we recently looked at in some studies was the risk of relapse early on. And it seems like the risk of relapse is highest within the first 5 years and then tends to be lower after that. So that might tell us that that might be a time point when we could potentially stop the medications. We could treat for 5 years, and then maybe we'll come off the medications to not increase the risk of infection. But some people end up being on long term. Other people will wean off earlier if there's problems with medications. And many patients who might be on the call here and physicians will be well aware that oral steroids, the IV steroids, are really, really useful. They give a quick burst. They can have some complications, sometimes cause some confusion, insomnia for a few days. But when you use them just for the short term, they don't cause a lot of long-term issues. But when you use oral steroids for many months, then you can get a whole lot of problems. They can affect your cardiovascular system. They increase the risk of diabetes. They cause very significant weight gain. They can cause puffiness around the face and a change in appearance, something we call Cushingoid appearance. They can cause cataracts, glaucoma. They can cause mood irritability. Patients and family members will know if the patients are on steroids, and they tend to have a lot more anxiety, mood issues. It can be quite difficult. And it can affect the skin. It can increase the risk of acne. There can be thinning of the skin. It can affect the bone health too, particularly for growing children. So while they do seem to work well for MOG and preventing attacks, we have to be very careful about how long we use them for. Some people will propone to use them for many, many months, but we have some concerns that that might cause a lot of side effects. So there are some patients who will quickly relapse after their initial attack. And in those patients, Sometimes we will put them on steroids for a short period of time, like 4 to 6 weeks, and try and get them off quickly. Other people will use them for longer to try and prevent those relapses, but again, you have to weigh up the benefit of that versus the risk of many of these different complications. So this is a challenge in the field, and I think we need to study more to identify those who would benefit most from steroids and not overtreat everybody else. And I think that's more work we need to do in the research community. Now, there's been some people who've treated patients after the first attack, and it seems like if you do start them on treatment, that they may reduce the risk of relapse. But then also, we don't want to treat everybody after the first attack, because up to half of those patients will never have a second attack, and we don't want to increase the risk of relapse for those. So sometimes we'll select out people who had a very severe first attack, like if you had a life-threatening attack, we might want to start treatment right away. Or if you don't recover well, if you're left blind in one eye, then we might want to start treatment right away after that first attack. Otherwise, we may observe and see if you have a second episode and then consider adding in the treatment. So as I said, this is some of the ideas about when we would treat and what treatments we use. So we'll move on just to some of the treatment options. Many of you might have heard of a medication called rituximab. So rituximab is a medication that targets your B cells, and your B cells are the cells that make your antibodies. So we talked earlier about removing all your antibodies with plasma exchange, neutralizing them with IVIG. Another way you can get at them is prevent their production. And that, in a way, rituximab kind of can do that. It also has other mechanisms, but that's one of the major mechanisms of rituximab. And for some reason, it works very well. Rituximab and other B-cell depleting agents like inebilizumab or ocrelizumab, these medications work extremely well in multiple sclerosis. Many of these, particularly ocrelizumab, ofatumumab, ublituximab. But these B-cell depleting agents don't tend to work quite as well in MOGAD. They do work very well in aquaporin-4 positive NMOSD also. So they may still have an effect, but studies have suggested, here you'll see the dots as relapses, and when people went on rituximab, it didn't really change that much. You'll see some of these dot plots later on, you'll see with some of the other treatments, and here you see there was still lots of relapses in these patients, despite the rituximab doing its job and removing all your B cells. Some patients were still having relapses. And when they look at all the data, it still may have some effect. It may have some benefit favoring rituximab, but it's a milder benefit than we see with some of those other conditions. So it's not really our first-line favorite treatment to target those B cells. IVIG, as I mentioned earlier, is a medication that will neutralize your bad antibodies. And this was a study led by John Chen, the Mayo Clinic in Neuro-Ophthalmology, and Romain Marinier at Lyon. And they looked at IVIG as an attack prevention treatment, and they pooled all their patients. This is an observational study, not a clinical trial. But it seemed like after patients went on IVIG, particularly more than 1 gram per kilogram, or what we call high-dose IVIG, more than 1 gram per kilogram once a month, that those patients had a lower risk of relapse. So it looked like a good option in terms of treatment. And at Mass General, Michael Levy and Philippe Bilodeau showed here, they compared many of the different treatments, like rituximab here, as we said, and it seemed like IVIG looked like the best of the treatments here. They didn't have the IL-6 receptor blockers here, but IVIG looked like a good treatment and a promising treatment. So that's an option that we often use while we're waiting for some of this data to be available. You can also give this subcutaneously. This was a study done at Johns Hopkins, where you inject the immunoglobulin not into the vein, but actually under the skin in the belly. And that's another way of giving subcutaneous, what we call subcutaneous immunoglobulin, or SCIG. And that also looks like a promising option for MOGAD. And the benefit of IVIG and subcutaneous immunoglobulin is it does not lower your immune system. It is challenging. It can provoke headaches and sometimes cause some mild inflammation of the meninges. It can also be associated with clots. It does have some risk factors, but it does not lower the immune system, which some of the other medications do. So we'll talk more about that later. And now we'll move on to the interleukin-6 receptor blockers. We talked a little bit about those earlier. The IL-6 is kind of like the fuel for the immune system, so we're trying to block that fuel so they don't have that fuel to make those antibodies. And here again, you see a dot plot. This was of tocilizumab, just a small number of patients, 16 patients here in this study. But what you see is all these red relapses seem to really go away when patients went on this tocilizumab. So it looked very good in this observational study, not a clinical trial, but still looked very good. And it can be given IV or can it be given subcutaneously. And then there's a couple of other studies that looked at interleukin-6 receptor blockers with something called tocilizumab, and that seemed to work very well in those studies. We recently did a study looking across North and South America. This was a larger study, and many of the other studies just include 20 patients or less, but this included 116 patients, of which almost 20% were less than 18 years, and most of these patients had relapsing MOGAD. And these patients were treated with tocilizumab, which targets the interleukin-6 receptor, or satralizumab, another treatment targeting the interleukin-6 receptor. And the median annualized relapse rate went down from 0.64 to 0.09. So what you'll see here in the image, you'll see lots of relapses here in the black, and then much less relapses. Each row is a patient here, much less relapses after starting the treatment. So it seemed like the frequency of attacks went from 2 attacks every 3 years down to 1 attack every 10 years. So looked much better. Some of these patients, this medication does lower the immune system. Some patients had risk of severe infection. So that's something you need to watch out for. In this study, we also compared to IVIG, and what we found was that the tocilizumab and satralizumab, the interleukin-6 receptor blockers, seemed to work better than low-dose IVIG, but not different to high-dose IVIG. So similar, or if anything, maybe a slight trend towards being better than a high-dose IVIG. So interleukin-6 receptor blockers is something that we often use off-label. Again, we don't have any FDA-approved medications. But recently, this was presented at the American Academy of Neurology annual meeting last year by Michael Levy. And this was a clinical trial. And that's really the best evidence we can get, because this randomized patients into either receiving the medication or receiving placebo and not receiving the medication. So a really high-level result, much better than some of those other studies that we showed that were just observational studies. So this was a real clinical trial where the doctor didn't know if the patient was getting the medication, the patient didn't know if they were getting the medication, and it was looking at this medication satralizumab, which is also an interleukin-6 receptor blocker. And I won't go through the details here, but there is some suggestion that this IL-6 seems to be important in the mechanisms of MOGAD, and therefore they did these studies targeting the interleukin-6 receptor, and this seemed to work well in that other condition we mentioned earlier called aquaportin 4 positive NMOSD. So suggests that it was worthwhile trying in this trial. This was the trial here. The trial included adolescents, so down to 12 years. Most of the patients were adults, but some children were also in the study, and patients had to have had at least 2 attacks. And then they were either randomized to the satralizumab treatment or to placebo. Some patients remained on their home medications also. This is what this IST is for here. And then the endpoint of the study was the time to the first relapse. So they see which group would relapse quicker and which would the medication help prevent relapses. And here you'll see the final results. What you see here is that the satralizumab group here on the top, that they had less risk of relapse, and that more of them were free of relapse. Up to 85% were free of relapse here in follow-up, compared to 54% of the placebo group. And therefore, that was a 68% reduced risk of relapse in the satralizumab group. So this was really exciting, because this is the first time we've had a medication that looks like it's effective for MOGAD. Now, this medication is not yet FDA approved, but in the future, it may become FDA approved. So seemed to work well in this condition. They looked at some of the secondary endpoints, and again, looking at annualized rate of relapses, how many MRI lesions you had, how much rescue therapy you needed. It seemed to work very well across all of those endpoints. And they looked at safety too in this trial, and the medication seemed to be fairly well tolerated, with slightly higher injection-related reactions in the satralizumab group compared to the placebo, but otherwise they didn't see any trend of increased risk of infections or any other concerning findings. There was one patient who ended up having a cancer a few months after joining in the trial that they think was unrelated to the treatment, and they had passed away. But in terms of the infection side effects and other ones, seem to be a relatively good safety profile, which is what we've seen in the other studies. And there are some other clinical trials now underway. They've not yet read out. One is called rozanolixizumab. This is like that plasma exchange treatment that I mentioned earlier. It kind of removes your antibodies. It targets them for removal. So there is a recycling process in your body that recycles all the antibodies And this kind of prevents that recycling of antibodies and targets them for removal. So it removes your antibodies, and in that way, it's quite helpful. There's a few other trials. There's one of this interleukin-6 receptor blocker called tocilizumab in China that we're hoping may read out soon. There's a trial of azathioprine, that's another immunosuppressant in MOGAD in France. And then there's the STARMOG trial in Australia looking at rituximab, that's that B-cell depleting medication. We weren't sure it works quite as well, but the clinical trial should be really able to answer that question definitively for us. So it's very exciting that we have lots of trials available. There have been other novel treatments tried. There's a treatment called CAR-T, which is where you engineer your own immune system to target the bad parts of your immune system. And this is a CD19 CAR-T that can target some of those cells in MOG, and it seemed to work pretty well when many other medications had not worked well. So more studies to come. This is just a single case. And there's also been some studies where they did a stem cell transplant where they kind of shut down your immune system and try and reset the immune system and see if that will work for the condition. And this was a patient who was very severely affected, and it seemed to work well. But again, only one patient, so we need more data because some of these procedures have a high risk of complications. So they're not for everybody, but are potentially for very severe cases. And in the future, we'll need to study them more or see if we can get these treatments to be more safe, and then they may be options more widely available. We don't know when to discontinue treatment in MOG. I mentioned this a bit earlier. We often treat for 3 to 5 years, but some people will withdraw treatment early. Up to 10% of patients can relapse in the first year after withdrawing, and even 20 to 25% in the second year. So people can go on to have relapses, but usually they don't develop permanent disability from those relapses. So it is something we should consider. You know, we don't want to be treating everybody lifelong with these potentially risky medications. So something we need to learn more about and do more research on. So I'm going to conclude here, and I'm just going to highlight that there are many therapies emerging in MOGAD with the potential for approved treatments in the near future. So I think we're following that trajectory of NMO and MS, where we're getting lots of new treatments that will be coming soon. And that will allow us, you know, we often have difficulties with insurance approval and things, but if we can get proven FDA approved medications, then those can be available. And then we want to make treatments more available around the world. And that's why we're talking about some of the other alternative medications like tocilizumab is available more widely around the world. And that might be a good option for around the world where some of these other treatments might not be available. And just to highlight, you know, there are many different people researching in MOGAD. It's a really hot topic. Everyone's excited about it. Everyone wants to study it. And we are so appreciative of all the patients who give up their time, are willing to participate in research so we can learn about this. And because of this, there is a lot of hope out there for patients with MOGAD. MOGAD 10 years ago, very difficult. We only just had the antibody test available. We could make the diagnosis. We had very few treatments. And now a whole lot of new treatments coming. So I see a lot of hope on the future for our patients with MOGAD and lots of new things to come. So I'm going to stop here. I'll acknowledge this is our neuroimmunology group here at the Mayo Clinic who were involved in some of these studies that I mentioned. We have Dr. Wingerchuk also at Mayo, Arizona, Dr. Irani and Lopez Chiriboga at Mayo Clinic, Florida. And then we have many different funding partners. The NIH has funded us for MOGAD studies and grants. And we had a big collaboration across North and South America. We can't do this alone. We have to collaborate. And finally, we have to remember the patients. We had a MOGAD patient day at Mayo Clinic, and there's many patient days. I know the Health Alliance will be doing many patient days also. And, you know, there is a motto at Mayo Clinic, the needs of the patient come first. And we really want to focus on the patients. And the patients, every time a patient tells us a story, that is where we learn for the next patient. And every time a patient participates in research, then that's how we learn for the future. We've had many people who've spent so much time in these clinical trials, but they're giving to the next generation of people to find a proven medication to make the lives of patients with MOGAD and other neuroimmunology conditions better. So I'm going to stop there, and I'll allow Dr. Eoin come back in, and we may move on to some question and answers. Thank you for your attention.
Dr. Flanagan, thank you so much for a great review of this really important topic. It's, as you say, a prominent area in the field. Many people interested, a lot of hope. Thank you so much.
Yeah.
We have time on for a few questions, if you would, please. So, you know, when you approach acute treatment of a typical MOGAD attack or relapse, what is your approach, and is early treatment important along the lines you mentioned, different types of strategies, how would you kind of compare those?
Yeah, I think it is really important. For people with MOGAD, you don't want to sit on it. It's most commonly going to be that optic nerve inflammation. So sometimes when patients have pain with eye movement, even before they lose vision, that can be a window for those few days when they have eye pain and pain with eye movement, that they could get in quickly with steroid treatment. And usually steroids are our mainstay, and that might be that 5 days of IV steroids or that very high dose oral steroids, that steroid in the pocket approach. And I think if you can get in, you can really resolve it much more quickly and leave less damage. And in that way, you can recover better. And then, after that, you may need some adjustment of your maintenance treatment. So I think early, and MOG tends to be very steroid responsive. So a lot of times patients will improve in many days. So I think early steroids is key. But then if you're not better, you really need to consider whether you would move on to that plasma exchange. So if you're still having a lot of vision trouble after the steroids, that's rare, but it does happen, then you need to move on to those additional treatments so you're not losing permanent vision.
Thank you so much. On a similar note, another question relates to steroid tapering, and you emphasized the issues of long-term steroid use, Eoin, as compared with, less chronic use. Can you just kind of give us a synopsis of, the approach to steroid tapering being balanced with prolonged oral steroids relative to significant side effects?
Yeah, it is a real challenge for us in neuroimmunology. Many people with neuroimmunology conditions, they will come and tell us that they hate steroids. They don't like them. They cause a lot of side effects. They cause change in appearance. It can be very difficult for adolescents who some of our children have been bullied in school because they've gained weight or they develop skin changes and things. So it is a real challenge, particularly for growing children. There's issues with bone health and things like that. So I think we need to do a better job about figuring out which patients really do need a bit longer steroids, but trying not to have it too prolonged. Because if you prolong the steroids for many months, then you increase the risk of osteoporosis. There are a lot of different side effects with the steroids. So we try to balance that out and try not to do too prolonged a steroid taper, even though it does work. And some people will need it because they have such a severe course that we don't want them to permanently lose vision. So there is that balance, but I think more research to come is needed to try and identify those that we can do better, or maybe there's alternatives. Could we use IVIG or could we use interleukin 6 receptor blockers instead of steroids to get us through that high risk period? So I think we need to be thinking outside the box a little bit and trying to avoid those steroid side effects.
Thanks a lot for that summary, Eoin. On a different sort of note, you mentioned about 50% of patients only have one onset episode and never have another, monophasic, if you will. What's your typical approach to a patient who completely recovers after their first attack, but you don't yet know whether that's going to be the only event they will ever have?
Yeah, we tend not to put them on longer term therapy in that scenario, and we tend to often observe, particularly if the first attack was not very severe, they weren't in a coma, they weren't, it wasn't a life threatening attack, because many of those patients won't go on to develop a future attack, and if you put them on, immunotherapy for years, you're going to increase the risk of side effects. So we tend to observe those patients. Sometimes we'll follow their antibody levels and see, in that scenario. And some people have used that where if the antibody goes negative, then they're less likely to use treatment. So different people have different approaches. I think you just got to be aware that there is that potential that it's only a one-off. And for those patients, that's great. And you may not need the longer term immunotherapy. So it is an option to observe many of those patients. But in people who don't recover well, or people who, some people from their own personal choice, they want to go on immunotherapy for a few years. They're very concerned about the risk of relapse. And there's some kind of doctor-physician discussions that will be involved in that to make that final decision.
Oh, and without supporting data, do you, in your experience, see that there are patterns or themes in patients who are monophasic versus have relapsing MOGAD?
Yeah, there have been some, there's some evidence that suggests that younger children, particularly with what we call ADEM, that inflammation of the brain and the spinal cord that they can get, that some of those patients will not go on to relapse and have a lower risk of relapse. So some of our pediatric patients will be more reluctant to put those people on longer term immunotherapy, while in adults, there is a suggestion that maybe if you have optic nerve inflammation, you're older than 50, for example, that those people may be a little bit higher risk. But I think we still need to do more research, and this is why it's so important to see, is there any other predictors that we could find? Is there something in the blood? Could we look at the antibody levels? Is there something that we could do that could better tell us, who is going to relapse? Because it's a huge question in the MOG field. If half of people are not, half of people are, we need to know who we can treat so we prevent those relapses, but not over treat the other people. So it's kind of a big outstanding question in the field that we're all working. And I know we've talked about this many times. We're trying to partner on research to try and see, is there ways how we can predict future attacks and who's going to relapse? And then, we could select out those people to treat them only and not treat the rest.
Sure. Thank you very much, Eoin. For the patients who do relapse, what are your main options for sort of attack prevention strategies in your practice particularly? I know you mentioned, the escalation from steroids to plasma exchange or IVIG and then on to an IL-6 receptor inhibitor. But is there sort of a strategy that you use regularly?
Yeah, I would say, when the trials were open, we were often enrolling patients in the trial, but right now, those trials are fully filled up. So now we tend to use the interleukin-6 receptor blockers commonly as an attack prevention, or the IVIG subcutaneous immunoglobulin. But we do get into lots of issues with insurance because these medications have not been proven yet in a clinical trial fully that's published. So in the future, we're hopeful that if we can get some of these medications approved, we can get over some of those hurdles. And if we get FDA approved medications, then we may be able to move towards those and have less hurdles for patients. In some people, we might try these other medications we talked about, rituximab, mycophenolate, an oral type medication. But in our experience, the IVIG subcutaneous immunoglobulin and the interleukin-6 receptor blockers are probably the two favored off-label options that we use.
And just for completeness, Eoin, are there studies currently looking at C5 inhibitors in MOGAD for acute wound?
For complement inhibitors, yeah, not yet. I do think there will be some interest there. When we look pathologically, at least in some patients, over half of patients in our experience, will see complement deposition like we did with the aquaporin 4 antibody positive NMOSD, and the complement inhibitors work very well there. So I do think it's interesting if we could consider using those. Also, we tend to see even more complement deposition in those very severe cases, those life-threatening cases that I mentioned. So maybe in the acute situation also, there could be a role for those treatments where you've got a life-threatening episode and you would give one of those complement inhibitors to try and help take down that complement and prevent that cascade of the immune system. But I do think it'll be interesting in the future. It's important for us to see what options and to have many options, because not every medication works in every patient, and for whatever reason, there are medications that are not a good option for people. So the more we can have available to us, the better. So I do think we should look at complement as a potential treatment option.
Relative to your last comments there, Eoin, no drug is perfect and many of them can have important side effects. How do you sort of consider an algorithm or a strategy for potential side effects when you're choosing a treatment to prevent relapses?
Yeah, exactly right. We have to kind of look at this. And also there's logistical concerns. Some, particularly children, don't like needles. So IVIG can be hard on children when you have to give quite frequent injections. You might have to give it once weekly or give subcutaneously once weekly. So in some of those, we've moved to monthly with interleukin-6 receptor blockers or other things. So IVIG can also cause some headaches and some meningeal inflammation. So it can be hard to tolerate. And in that situation, we would try and move to something else. But also, in some people, we're more concerned about infections, older people particularly, or if they've got other comorbidities, then IVIG, subcutaneous immunoglobulin, can be a good option because it doesn't increase your risk of infection. So I think we're always trying to consider these aspects in our patients to try and match the best medication to them. And that's why it's so important in the future. If we can have many different options, then we can get the right treatment for the right patient. And I think that individualized treatment approach, if we can get many different treatments, that's going to be important into the future, like we do with NMOSD or with multiple sclerosis.
Well, Owen, thank you so much. We really want to thank Dr. Eoin Flanagan from Mayo Clinic for his masterclass today regarding MOGAD. You can find additional information about NMOSD Masterclass on the Patient Health Alliance website, and you'll see the featured speakers, educational events, presentations, and other media. You can use the QR code shown here. And finally, we want to thank the major sponsor for the NMOSD Masterclass, which occurs by way of an educational grant from Alexion AstraZeneca Rare Disease. This concludes today's masterclass. We hope everyone is doing well, and thank you very much for your attendance.